Okay, thank you very much, and thanks to the organisers for inviting me to join in the biggest IWCLL ever, to date anyway. Okay, so there's my disclosures. I'm not going to talk too much about the diagnostic approaches. I'm mainly going to focus on flow cytometry because there's lots of sessions about molecular diagnostics afterwards. I think the only thing to point out really was that we had a harmonization effort trying to find a way to consolidate the sorts of markers that should and maybe you absolutely had to be included in a diagnostic panel and others that would be recommended. And just to give you an overview of what those would look like in the different disorders, obviously the molecular diagnostics plays a major role in the diagnostic pathway, but I did just want to highlight something that's relevant to MRD in that the typical phenotype with the absolutely essential diagnostic markers highlighted in red there. Within those typical phenotype cases, it's extremely rare to see a cyclin D1 mutation, occasional MYD88 mutations. But those ones are the ones that are absolutely ideally suited to MRD monitoring by flow cytometry. Whereas the others with atypical markers, I think you have to be cautious about assuming that the MRD assessment will work. You also, of course, have to be aware that the driver may not be known if they don't have a cyclin D1 translocation or a MYD88 mutation. And these are quite a high proportion of overall CD5 positive cases, many of which are getting referred for diagnosis and treatment as CLL. Okay, so in terms of minimal or measurable residual disease, I think we're all kind of aware of the history as treatments have improved. Back a couple of decades, well, a decade and a half ago, we were starting to see patients where more than half of patients were in CR, and a more sensitive measure of response assessment was required. At that point also the assays came together and you had assays that could directly measure the disease rather than looking at relative proportions of normal to neoplastic cells. So the molecular and flow cytometry methods both went quantitative, directly quantitative, and then you started to see in clinical trials really useful information about which patients were doing best, and that information was independent of the treatment type. So then we had a little interim period, the sort of ibrutinib monotherapy era where MRD was not relevant. Patients were having sustained remission with still quite a lot of disease present, and the duration of remission didn't seem to correlate with the level of residual disease. But of course, as we've seen, we have issues with resistance. Continuous therapy is, of course, costly, and there's been a recent move back towards fixed duration therapies. And I think what's been encouraging to see this year, apart from the very good responses, is the fact that MRD still is entirely predictive of what's going to happen over the subsequent years. So the patients with less than 0.01% disease have durable remissions, and those patients with more than 1%, with the high MRD, as it's often called, they're the patients at risk of progression within the next couple of years. And actually, the kinetics look very similar to disease progression after chemoimmunotherapy. So lots of the things that we've learned from chemoimmunotherapy apply also here in the venetoclax B-cell receptor pathway era. And of course, the issues that were relevant with chemoimmunotherapy are now also back to the front in that the responses are great, but this means, of course, for designing trials, with progression-free survivals that are almost flat, as we saw at the ASH session just last year, several different treatment strategies which would give you 100% progression-free survival for several years. It means designing trials is, of course, very difficult, challenging, which has led the regulatory agencies to consider MRD as an intermediate endpoint. In Europe, it's already possible to get an early license based on the MRD information, as long as you can confirm the benefit with progression-free survival subsequently. And the FDA have issued draft guidance on how to approach this for new drug development. So I think the next few slides I'm just going to bring together a few points about how some slightly different aspects about how the IWCLL have put MRD into the guidelines versus how FDA and EMA have put those in. So there's, of course, a lot of concordance, and everybody's centered around a threshold of 0.01% or 1 CLL cell per 100,000 leukocytes. And it's slightly differently defined, but essentially the same threshold. That's different to other disease categories. So in myeloma, it'd be 1 in 10 to the 5. In AML, it may be 1 in 10 to the 3 for some techniques. And I think it's quite important to stick to that threshold. What's been a real challenge in other disorders is if people try to move the threshold, then all of the information you had about the earlier threshold is almost lost. And because it takes years to look at outcome, to obtain outcome data, you just lose so much if you suddenly shift a threshold without really thinking about the consequences. So in terms of a clinical assessment of response, I think it's really important to stick to that 10 to the minus 4 level as a uniform threshold for CLL. Reporting the proportion of patients on an intent to treat basis, I think that's fair enough. And any assay that's been validated is appropriate for the regulatory agencies and for the IWCLL. So in fact, the FDA put it as they're agnostic to which technology platform is used. And that leaves a few different options open. As I say, there's going to be a big session on high-throughput sequencing later on. So, but the rest of the slides here will probably be appropriate for any technology. There are some variations. So, in terms of clinical response, for a regulatory agency, they would only consider MRD negative or MRD undetectable to apply to patients who are in CR. This isn't specifically stated in the IWCLL guidelines because we all know that actually there are patients who are in a PR by the guideline definitions who do extremely well. And the challenge, I guess the reason the regulatory agencies have to take the harder line is that, that's quite sensible. For us, the difficulty is that it depends on the treatment. So if you're in a chemotherapy area, this is the German CLL study group data, and we also see similar things in the UK in the ADMIRE and Arctic trials, in that the MRD negatives with mild splenomegaly, MRD negative partial remission, actually do slightly better than MRD negative CRs. But there is a group of patients who are MRD negative but with residual lymph nodes. And in the chemoimmunotherapy setting, they seem to do slightly worse, closer to an MRD positive CR, although both of those groups are better than an MRD positive PR. If you look at venetoclax rituximab, it's completely different. So it looks like those residual nodes that were seen, there the PR MRD negs seem to do just as well as the CR MRD negs. So there's a lot of work to be done to try and resolve these issues, but I think in terms of the CLL community, we need to be looking still in peripheral blood and bone marrow at patients who may have residual nodes to understand what it means. For a regulatory agency, they will only consider MRD undetectable in a CR patient. And then so the other, I guess, big issue is peripheral blood or bone marrow. So the EMA said to go for peripheral blood first and then confirm in the bone marrow. And the FDA also said confirmation in the bone marrow as well. The IWCLL was, it may be important to confirm that the marrow aspirate. And I think the reason for being cautious here is that you don't want to design a strategy that requires patients to have multiple sequential bone marrows to determine whether they are MRD positive or MRD undetectable, if that's going to be used to define subsequent treatment. So how do we resolve that? I think in the UK the approach has been to try to design trials where you have as much peripheral blood information to help you determine when a bone marrow would be appropriate if it has to be done. And for the final response assessments, I think in trials, still you have to look at both compartments. The discrepancies vary according to treatment type. So for chemoimmunotherapy, there's about, with rituximab being the anti-CD20, that's probably the thing that's causing the discrepancy, you're talking about nearly a log difference, but 2 log differences are quite rare. So the number of patients who'll be negative in the peripheral blood but actually have high or greater than 1% MRD in the bone marrow, relatively few. And so broadly speaking, you'll see a similar outcome, but the curves will separate 4 or 5 years out. Ibrutinib on its own has no difference between the compartments, but if you add in obinutuzumab, you're seeing the ibrutinib seems to counteract the obinutuzumab peripheral blood depletion difference. So you're only looking overall about a 0.4 log difference, but there are a significant proportion of patients, 10 to 20%, who have more than 2 logs difference between peripheral blood and bone marrow. So I think if somebody's on obinutuzumab, then you definitely need to be looking, or recently off obinutuzumab, you definitely need to be looking at the bone marrow to get a sensible answer about the MRD status. For venetoclax combinations, it's probably about half a log difference. So broadly speaking, the peripheral blood gives you a very good indication of what's happening in the bone marrow, and that seems to be consistent through all the time points. So trying to deal with how to measure MRD status with anti-CD20s involved, this is the German CLL14 data. The discrepancy is still at response assessment. You can see if you have a lesser response, then probably the difference is going to be greater. If everybody's had a very good response, then you may only have a smaller difference in terms of the proportion of patients who are negative, but you'll still see a substantial difference. And you have to remember that the rituximab and obinutuzumab half-life may be about a month or so. Not entirely sure of the exact half-life, but in terms of the practical measurement of when the disease is, when the therapeutic antibody is cleared, if you look in post-FCR, 3 months after treatment, most patients don't have any normal B cells. They've got lots of normal progenesis in the bone marrow. As soon as the rituximab is fully cleared, you start to see normal B cells coming out. So it's about 6 months after rituximab before you're seeing half of the patients recover their normal B cells. And by 12 months after, most patients have normal B cells detectable. So that's a kind of idea of how long it's going to take to clear the peripheral blood discrepancy. And we've seen that in ibrutinib and obinutuzumab treated relapsed refractory patients in the ICICLE trial, where the obinutuzumab stops at 6 months, but the peak response here is another 6 months after that. And that's a combination of the fact that they're continuing to respond to a certain extent to the ibrutinib, and you'll see graphs like this, big depletion, and then as the obinutuzumab clears about a year after, you'll see a rise. So then that's the B cells coming back into the peripheral blood, CLL cells and B cells, and then a subsequent ibrutinib response. So it is actually quite challenging to use the peripheral blood when reagents, therapeutics like obinutuzumab are in the mix. And so I think multiple time points are essential for interpreting the information there. Now, I said that we should really be sticking to 10 to the minus 4 for our clinical threshold for reporting response, but there are situations where you might want to look a little bit more deeply. If you know there's a half a log difference between the peripheral blood and bone marrow, then actually going up a sensitivity notch in the peripheral blood means that you get a better idea of what's going on in the bone marrow. So the patients after 6 or 12 months on venetoclax who had between 0.001 and 0.01%, so 10 to the 5, between 10 to the 5 and 10 to the 4, only about half of those had actually cleared below 0.01% in the bone marrow. Whereas if you looked below 0.001% in the peripheral blood, then nearly all of those had, and the ones that didn't were quite close to the threshold. So there are situations where you might want to go a higher sensitivity to give you the information you want at the standard level. A slight issue for those of us doing the actual assessments is that the FDA may be looking for something that's been validated tenfold below the clinically relevant threshold. So for CLL, it's not so bad. We need to have assays that are 10 to the minus 5 if we're going to report at 10 to the 4. But if you want to report at 10 to the 6, then maybe you need to have an assay that's validated down to 1 in 10 to the 7, which is certainly challenging. Okay, so I've got a couple of slides. I just want to talk about the understanding MRD as a continuous variable rather than a discrete, discontinuous. And if you look at the 1%, 0.1%, 0.01 to 0.1%, and then less than 0.01% after chemoimmunotherapy. And we're seeing a similar sort of kind of pattern with venetoclax-based therapies as well. So for 2-year PFS, there's only really patients with more than 1% disease who have a risk of progression. You can't see a difference for the more sensitive thresholds. And that equates to the survival curve here, but 2 years, they're not really separating. But if you look at 5-year PFS, this is when you get the correlation according to log depletion. So this is why You know, the main value of looking at MRD assessment at the end of treatment gives you an idea of what's going to happen in 5 years. It doesn't say what's going to happen in 2 years. And you see the patients with an intermediate level of disease, the curves meet up with those with a higher level of disease after 5 years. So it does mean that you should be looking at MRD as a quantitative variable, not a yes/no. And the levels have different applications. So high MRD, well, this is relevant, say, for looking at patients who are maybe hadn't had an optimal response to therapy. They're in CR, but the ones with 1% are the patients who are going to relapse within the next year or two. Whereas if you want to go for a cure, you're going to have to get absolutely everybody below the level, the most sensitive level you can measure, if you're going to see long-term progression-free and overall survival. So I think I'd have one plea that maybe we should really reclassify greater than 1% as a partial response. There used to be a mechanism in the old criteria that if there were clonal B cells detectable in the peripheral blood, then that should be considered a PR. And if you look at PR for chemoimmunotherapy, actually patients with 1% or more do worse overall, and that's even within the CR group. So there's the PR line, and there's the patients in CR with more than 1% disease. So these are effectively patients who have had a partial response, and maybe we could look at reclassifying that, cutting down on the amount of bone marrows that people have to have in clinical trials. So the problem with the threshold is that it doesn't really work for anybody. If you take a certain threshold, then maybe a higher threshold is probably better for actually licensing drugs, because it gives you a much easier trial design and identifying the people who you want to get rid of the people with higher levels of MRD, and so a higher MRD threshold is good. But if you want to go for a curative therapy, then the most sensitive measure possible is the best one. So I've done this poll around a variety of people. This was quite an interesting one. So in terms of looking for curative, then pretty much everybody wants the most sensitive threshold possible. But if you're looking for drug licensing, something like 10 to the 4 or even maybe 10 to the 3 is actually very useful. But nobody is happy with the current guideline, so it doesn't really work for all applications. A single threshold doesn't really work for the different applications. So that's kind of led to a group of several people from the molecular and flow side and cellular side trying to find some way to give an indication of the quantitative nature of the residual disease in different disease settings. So I think you can't get away with some binary classification. And the reason I've put pos-neg there rather than detectable, undetectable, is because when you say this patient has undetectable disease at MRD4, but then you also know that they've got detectable disease at MRD5 or MRD6, it becomes quite tortuous to report that. And some simple pos-neg binary yes/no at a certain guideline threshold is actually useful. The key thing is to make sure that you only ever say pos-neg referring to the guideline threshold for that disease. Otherwise, it's just the information is lost. And then some way to say what's the level of disease. Is it MRD, was it 1 in 10 to the 4, 10 to the 5, 10 to the 6? And then after that, if you have MRD4, if you've got less than 0.01%, but you do know that they've got some detectable disease, then that's different to patients who have no detectable disease whatsoever with the assay, but they're undetectable because the assay didn't go further. So I think this is open to debate for discussion, but to maybe just think about the fact that MRD needs to be looked at different levels. And then in the final couple of slides, just saying MRD, in terms of the guidelines, desirable in clinical trials, not generally indicated in routine practice. But if you look at the way that the community is moving at the minute, certainly about half of people, possibly more, are suggesting that we should be using it in general practice. So 2 examples of how we are using it and have been using it for many years that probably everybody's doing in some way or another, but they're not really calling it MRD testing, is looking for response, especially for patients with cytopenia on treatment. Have we actually got rid of most of the disease? And the cytopenias indicate that the treatment is becoming toxic. That's been stable for several years and probably people are already doing it. Something that's been fairly new is to start using MRD to monitor patients. So if there's no detectable disease in the blood, they're not going to progress within the next year. So this is a postal service for patients who are more than a year off treatment in remission, And we see a variety of different patterns that we can readily monitor through the post and work out when they need to come back into clinic. So on that, I will finish and say thank you very much for your attention.
Thank you, Dr. Rawstron, for the excellent presentation and for being on time. So this presentation is now open for questions. Please come to the microphone and identify yourself. So while we wait for the audience, do you propose to have different MRD goals according to the treatment, the age, and whether you are measuring it in the peripheral blood or in the bone marrow?
So so the results of the German CLL14 trial give us the indication that you can achieve very deep remissions in elderly patients with comorbidity. So, that was an initial problem, was that if you went for low levels of disease with treatments, that those treatments might not be applicable to the elderly. I think it purely depends on the clinical setting. For multiply relapsed patients, actually getting below 1% might be a really good target. And I think that's a problem. If you set the target too high, certain patient groups won't be able to benefit from these assessments.
So we have a question, Dr. Rai?
Yes, thank you, Andy, for teaching us about the reality of MRD undetectable. My question, and that I had hoped that you would address over the decades, is an analogy that we refuse to include in assessment of the power of MRD in CLL, is the comparability of chronic myelocytic leukemia in the post-imatinib era, where the data over the last couple of decades is pretty solid in BCR molecular remissions, and nobody is claiming that those patients who are now on 10, 20 years on imatinib type of therapy and living a full life, nobody is claiming cure or uncure. Could we aim towards that kind of assessment in CLL?
Well, I think we have a large number of patients who are on that. So the people who are receiving ibrutinib monotherapy at the minute are sort of in that setting, and actually the postal service we started there was designed for CML patients. So all of our CML patients in the region are monitored through there with an interim clinic assessment. So the decision about how to approach the treatment is more driven by the people out here rather than the MRD result. It's been interesting to see with the ibrutinib monotherapy that actually just a simple B-cell count really gives you an indication of what's going on. So we've got a poster about those patients who remain stable. Actually, the B-cell count is either decreasing or remarkably stable. So even if you see a slight rise in the B-cell count whilst you're on ibrutinib, all of those patients, 75% of the patients have already progressed and the others have rising counts. So, I think it's already happening to a certain extent, but the clinical approaches, the treatment approaches have moved on to something where you can stop it. So that would be my answer to that.